Anyone wanting to utilise this model, it's very easy to find. You just go to the RDI website, there it is. It asks you some simple questions about your patient. You plug in the answers and boom, 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 your answer's there for you.
The RDI model is simple enough that if you've got access to a computer and the internet, you could find an answer for the problem that you have. So a patient comes in, failing therapy, you get on the web, put the data in and get your answer back.
I think one of the great strengths of the RDI model is that anybody can use it. All right. Clearly, most people would believe it would be more accurate to use it if you had a resistance test. But interestingly, the accuracy is very high without a resistance test. So the prediction in the model can really help us just knowing the history and knowing what people have been on before as to what treatments would be best next time round. So it really is a very widely available model, particularly in the third world where resistance testing isn't going to be available probably for some years yet.
The RDI model is free to any user. There is no cost, there's no hidden costs. People are giving their data into RDI for nothing. RDI is making this system available to the clinician or anyone who wishes to use it totally free.
The output of the RDI model's important to the physician because they want to know what's the chance that they'll get their patient less than 50 copies undetectable. And so that's what the RDI will tell you. What is the chance that that will happen if you prescribe this new regimen to the patient?
The models that we've developed, we use to power our HIV treatment response prediction system, HIV-TRePS. And using that system, a physician can obtain predictions of the probability of response to combinations of drugs that they're considering using. Or they can ask the system to predict the response to dozens of alternative combinations of drugs that are in common clinical use around the world and rank those that are most likely to give you a response. In addition, physicians can put in their local HIV drug costs so they can add the annual therapy cost to the report that they obtain from HIV-TRePS, or indeed model effective alternatives within a certain drug budget. Using these different facilities within HIV-TRePS, physicians can really tailor the way they're using the models, and it becomes a very flexible clinical support tool.
The best way to utilise these models is to take your individual patients or perhaps your individual population of patients, put in the data which that patient has, that is the viral load, the CD4 count, previous drugs that the patient has utilised. Clearly, if you have a resistance test there as well, you can enter that, but most patients aren't going to have that. Out of that will come various different combinations which you could utilise. Additionally, you can actually put into the model, we have only these drugs. You can also put in the price of those drugs, and then you can get an idea of the ranking of the drugs, the chances of success of lots of different combinations.
Well, I think for the developing world, accessing the RDI model is very important, especially when it comes to if there's payment around the drugs. So you could actually say, these are my local drugs, these are my local prices, which is the most economical treatment that's going to work predicted by the model. If that's not an issue, you could say, could you please tell me from the model which drug combination of these would be effective? So you'd have a whole list. Or you could say, of the combinations that we use in general, which one of those would be the best one to go forward with? So it's a very flexible system in that regard.
So the RDI model can be used by anyone. It can be used by us in the United Kingdom, it can be used in the resource poor world. I think it's mostly going to be used in those places where there is availability of a limited number of agents, we have a limited chances of getting it right, we have limited clinical information. It's going to be in those areas where we need to get things right first time. And any information which may actually help that is going to be absolutely vital in our fight against HIV.
Obviously, it's always difficult, I think, to predict when technology is going to be most used. My own view would be that throughout most of the developing world, the average patient, the average clinician does not have access to resistance testing. So that's where its chief and immediate value is going to be. So instead of me trying to remember what each study showed, the RDI computer will tell us what predictively is the best treatment to use. So I think that's where it starts. Clearly, we still find it a valuable resource in the developed world where the resistance testing may be quite complicated, and therefore it will have values in both directions.
The real benefits of this system can be looked at in various different ways. Firstly, for the individual. Virological success means no infections, no tumours associated with HIV, and indeed potentially a normal lifespan. So for the individual, getting the treatment choice right is essential. Secondly, at a population level, getting the treatment choice right in that individual is also essential. That's because there's risk of transmission of HIV. If you've got ongoing viral replication, you may pass it on to others, potentially with the resistance already present. The model also allows us to factor in the different costs of different agents and see, by using potentially more expensive drugs, are we really gaining in the chance of success? Or can we get the same overall results by using cheaper options in that patient?